So in this episode, I want to talk about concierge medicine. And that's something that, 3-4 years ago, I had never even heard, like it had not come across my radar. I had no idea what concierge medicine was, that it was even a thing. So kind of talk about what it is, how it works, how it differs from traditional primary care, all of those things. And so I know you've been doing this for a few years now. Mm-hmm. So I guess one question I would ask is like, how do you feel about even that word, concierge medicine? Is there a better way to describe what you do?
Yeah, that's a good question. I don't know if I really, it is what I do, whether I like it or not, and it's not what I planned, being a concierge doc, but but I'm okay with it.
Yeah. I mean, I think it's for whatever reason, I think just that, that phrase concierge medicine has a feel to it that some of us are uncomfortable with. I mean, it's kind of what we do at OptiSpan as well in our clinical programs. But yeah, it's also, I haven't come up with a better descriptor. So, so maybe we can start though by talking about like, what is concierge medicine in your words, and how does it differ from traditional primary care?
It's kind of like if your best friend or your brother was an excellent physician and you were very close and you had access to his knowledge and everything. All of a sudden you have that in your pocket to be able to use. And so what I see it as, traditional medicine, which is great. There's a great place for that. And that's all, we've talked about that being very reactive and all those things. The physician-patient relationship is usually here, or there's a lot of boundaries between the physician and the patient. And what concierge medicine does is it takes a lot of those boundaries away. Like whenever you call your primary doctor or you call a physician, just because the way it's set up, a lot of times you can't get in for 2 weeks, or if you're a new patient, 2 months. And that's just the nature of how it's set up with the insurance-based model. So you remove all those boundaries and then you have access, and it creates a, closer relationship. Sort of. Yeah. I guess that explains it pretty well. But yeah, and for me, my interest in longevity and everything came from my interest for myself, and for our concierge patients. It's like you develop these relationships. It's like, I'm going to bring all these people with me. Everything that I learn, now. And we do the same thing.
Right.
And that's, and I mean, creates a tribe, so to speak, or,
as part of that, I know a lot of people are frustrated with when they go see their primary care physician, they get 10 minutes, 5 minutes with the doc. Like it's just like, it feels like they're just being sort of cranked through this assembly line. So you're able to spend much more time.
An hour
with your clients. Yeah.
Because it needs that level of, we're talking about your health, right? Everybody knows what's in their retirement fund, but they don't know a lot of details about their health because they only really get 10 minutes with their doc.
Right.
And oftentimes the doc is and I've been there, you're very distracted. You've got not only the room that you're in with the patient, but you've got 5, 6, 7, 10 other, you got a lot of the rooms going. If you're, in the ER, or if you're, in the clinic, they're moving pretty quick. And so they may be having a conversation and kind of trying to dial in with you, but they've got a lot of other things going on.
Right.
Yeah.
Right. And again, you touched on this. That's in part because of the way that primary care and healthcare in general is paid for through the insurance programs. So we're stating up front, one difference is in concierge medicine, typically, maybe always, there is an out-of-pocket fee that is not covered by insurance. So people are paying for this higher level of care and personalization.
Right.
Now, that doesn't mean that insurance won't pay for some of the tests that are done through concierge medicine and things like that, but there is an out-of-pocket component for this.
Yeah.
And the cost is quite variable. Right? So in your experience, what was your path to becoming, to moving into this type of care?
It sort of developed with, my interest in the longevity space is really where it came out of. My original training was emergency medicine and trauma. And so I was constantly being seeing patients with a chronic disease over and over again. And I started taking that to heart. And, whenever you're running a code on somebody having a heart attack that's, just a few weeks older than you are, and it's pretty alarming, and you want to do everything you can to not be in that position. And then that becomes, okay, I need to really focus on health span and lifespan. Um, and then, starting to do some training and go down the integrative, medicine path, and looking at it from a more proactive lens. And then that developed into something, well, why don't I bring this to my own community? When you're seeing other people treating, the rich and famous on the coast and all that kind of stuff, why don't I bring that to my community and really focus on longevity? And then, and that just kind of developed into a concierge-based model, and it really works well.
And to make it clear, because again, I think a lot of people don't really understand what this space looks like.
Yeah.
Longevity is relatively new, right?
Yeah.
But the idea of concierge medicine isn't all that new, right? There have been docs and clinics for a long time where people could go and get pay for this type of care, at least in the sense of more time, more personalization. I think we've seen, as the longevity community's expanded, two things. We've seen more providers want to go into this space specifically focused on longevity, or maybe more optimally health span. But we've also seen a lot of the docs that were doing this sort of concierge care co-opt the phrase longevity and start calling themselves longevity docs, which we don't need to really get into that. I think people could probably pick up on how I feel about that, but it does create sort of an interesting dynamic, I guess I would say. It's great that people are interested. I have some concerns that people who don't know anything about longevity are branding themselves as longevity experts, but that's a different story. But I guess one thing that it might be worth touching on is, I think, a lot of people have this perception that concierge medicine is only for the ultra wealthy. And how would you respond to that?
Not necessarily. A lot of our patients will do, they'll do catastrophic insurance for the big stuff. But for us, they'll use a health savings account or whatever, which is tax deduction and all that sort of stuff. So
that's actually worth double clicking on. You can use your health savings account, probably your flexible spending health account for concierge medicine if you have one.
And, another thing about a good concierge physician will help. I mean, medical care is like a jungle. It's like and maneuvering that from somebody who's already been through the weeds and knows where you need to go for problem X or whatever, and how to get you there in the most efficient manner. It just saves people a lot of time, because medicine in general doesn't do a good job of respecting your time. Now, if you're going in with,
tell me about it.
I mean, if you're going into the ER and your blood pressure is like 80/20 and you're having a really event, that's one thing. But a lot of the other stuff that can be kind of subtle, and can be serious too, we again, will make you wait. And it's just the nature of the way it's set up. It's not the physician's fault or the nurse's fault or whatever.
Do you think in general that concierge medicine is more proactive, more towards medicine 3.0 than medicine 2.0? I mean, I know you are.
Depends on the physician, right?
Right. So I guess that's kind of what I was getting. I still feel like it's kind of an uneven. It's uneven, even in the concierge medicine space, just like it is in the typical primary care space. But regardless, you're more likely to get certainly more time and attention and personalization if you have a concierge doc. Well, you don't have to talk about specifically. You can talk about specifically what you charge. You can sell your clinic if you want to, for sure. But and I highly recommend Kevin. Great guy, great doc. What are we talking about in terms of the price ranges that people would typically see, though, if they were to go out and start exploring this space? And in your experience, then I can tell you sort of my experience looking around the landscape as well.
Per year, it can be anywhere from $3,000 to $40,000-$50,000 a year.
Yeah. That's I guess kind of aligns with what I've seen. I think $2,500 maybe on the low end. Right, all the way up to $50,000, $100,000 in some cases. And again, certainly not always, but in general, like with most things in life, you're going to get what you pay for in the sense that the higher end programs are going to probably have more diagnostics, at least more comprehensive diagnostics, probably more personal touch you would anticipate, certainly at those prices. And then sometimes it's just like you're paying for a celebrity doc, right?
Right. Yeah.
Yeah. But anyways, that's just, I think it's worth pointing out that price range because I think, you know, 2,500, 3,000, 5,000 a year is actually affordable to a lot of people. And if you really do the math and think about, you know, what are some of the other stuff I spend $3,000 a year on, you know, a vacation, a 1-week vacation, you're going to easily spend that much depending on where you go. What's worth more, right? Your health or, you know, going to Hawaii for a week. I'm not saying you shouldn't go to Hawaii for a week, but I think just kind of reframing it in that perspective, you know, again, obviously people have to do what they feel is right for them in their situation. But to me, it seems like it's worth thinking about, is my health worth that level of investment?
Yeah. And so many people mine is just really melded to the insurance idea. My insurance doesn't pay for it, so I'm not going to do it. That really needs to, we really need to change the way we look at it. And then plus, as we get older, there's a real decline in the amount of physicians. A lot of physicians are, you know, leaving the practice or leaving that career completely.
Yep. And some of them are moving into concierge medicine because it lets them do more like the medicine they wanted to practice when they went to medical school, right? So they're very, I think, disillusioned with the current system that they're working in and want to find a different path. And I think you're right. I mean, this is a point that I often think about is we, especially in America, have been conditioned to think that, you know, our insurance should pay for it if it's healthcare. And I mean, the reality is even in the reactive disease care system, you end up paying a lot sometimes unexpectedly. You often find out about it well after you get your treatment, which is also frustrating. But I think we need to change that mindset because the insurance system isn't going to change quickly to, okay, is my health actually worth investing my money in, right? As opposed to, oh, if insurance doesn't pay for it, I'm not going to do it. That's just not, I understand why people have that feeling, but it's not in your best interest to approach your health from that perspective.
Right. I mean, if you can invest now, you're going to invest one way or the other, right?
You're going to pay for it one way or the other. Yeah.
Either now or you know, pay the hospital out through the nose that last 10 or 20 years of your life whenever you have that chronic issues. But, and then the time, you know, if we have a patient that needs a quick MRI or, you know, a dermatologist or whatever, it's not like they have to call or wait and get a referral and it's 2 months out. I mean, I'll call myself and make the appointment and get them, you know, get them in
and you
quickly.
do a lot of that yourself. So you actually, the doc getting on the phone with the client or with the referral center, the doc at the referral center. So that's another access piece, right? That's one of the things we've been thinking a lot about here at OptiSpan is this idea of an executive assistant for your health who can help you navigate that stuff and just take care of a lot of the friction and frustration that we all feel when we're dealing with the healthcare system as it exists today. So I think that's a real value add for a lot of people. And again, you know, we've talked about this offline, but, you know, I think I told you, I just recently had my first colonoscopy, right? And I was supposed to get it 4 years ago, right? I'm almost 54. And, you know, I called, got put on hold, left a message. They never called me back. I called again. Finally, I got so fed up. I'm like, fuck it. I'm just not going to do it. And that's because the stupid system has created all this friction. So if we can help people navigate that, they're more likely to actually do the stuff that's going to keep them from getting sick in the first place. So not that that's a bad excuse. Like I'm not justifying the fact that I waited 4 years to get my colonoscopy, but it's the reality of the situation. We all deal with this and it's not necessary, but the system isn't going to change itself. So can we help people? Anyways. So maybe talk a little bit about like, what's kind of the typical patient that comes into your practice?
For mine, it usually is somebody in their 40s or 50, and because there's a lot more interest in, you know, the wellness and longevity space. So a lot of them have to do with guys that have kind of gotten their financial house in order. They're kind of stabilized in their career path and everything. And they think, okay, I need to get this looked at now. I've been surprised and pleasantly so that there's been a lot of interest in that. And people come and they're actually pretty well educated in what they're looking for, due to, a lot of the content you put out and others like you. Um, so that's the usual patient, 40s, 50s. We've got some people in their 60s and 70s as well, but they want to get a real handle on things. And they want some guidance in that and kind of managing, uh, medical
Yeah.
issues. Yeah.
Yeah. And I know you've got a pretty set approach in terms of most patients go through a process, right? So like
Sure.
maybe to the extent you're willing to share, maybe take
Yeah.
us through the process of like, how does it work? Somebody says, I'm going to go see Kevin. I'm going to sign up for his program.
Mhm.
What do they experience as they're going through that?
So to make it as frictionless as possible, and I'm stealing that word from you, but they get a questionnaire, right? We need to know. I need to know everything about them. What you don't want to be in is you don't want to be in a situation where you waste their time. I want to know everything about them before they come in, so they don't have to repeat themselves or rewrite things over and over again. If they've already answered a question, it's not like they have to do it again.
Yeah.
So they at home on their iPad or whatever electronically, they fill this out, and then I read that within 48 hours before I meet them. And then whenever we sit down for our first meeting, they don't sit and wait or anything like that. They come on back and we sit there and drink some sparkling water and shoot the bull for about an hour and go over all their needs and concerns. And I go over, what I think is going on. And we build that rapport that first hour, because if we can't connect there, then it's not a good fit and we don't need to move on. But if it's kind of good for us to both find out that they're a good fit.
Right.
And then after that, we do all the specific testing. We have our phlebotomists go to them frequently and draw their labs and all that, so I can get all the biomarkers I need or whatever specialty test we do. And then we also get the VO2 max and the DEXA scan with the body composition, visceral fat, all those things that you've discussed. And then 2 weeks later, after my initial visit, I'll have everything back, as far as the biomarkers, because that takes a little bit of a time. And then they'll see our nutritionist who knows all the results there and kind of gives them some stuff, some areas to work on, or, things that can be helpful to them.
Sure.
Really kind of dig in. And then they'll see me for an hour and we'll go over all the results and our concerns and how we want to deal with that. And there'll be another hour visit, because it, again, takes time, right?
Right.
And from then they decide if they want to stay on as what we call an executive member or not. And if not, that's fine. And if they do, great.
And then it's a membership program after that, monthly. Yeah. And then I know you've got kind of a standard biomarker panel based on blood work. What are the things that you look for that differ from what most people are going to get in primary care? So like in primary care, you're going to, you're going to get glucose,
right?
Probably A1C, basic lipids,
Yeah.
right? CBC chem, but what do you do beyond that? And what are the things that you're most interested in that people probably aren't getting from their primary care physician?
Yeah. We look at, so outside of those things, we get expanded lipid profile, some of those things being, your basic cholesterol panel, of course, which everyone's familiar with, but on top of that, the LP-little-a, the ApoB specifically. And then, I just obviously want to look at some thyroid issue, reverse T3, T3, 3T4, TSH. We want to go through, of course, hormones and all that, but probably the most important thing would be insulin resistance markers, so fasting insulin, so the A1C, like you mentioned, but also like C-peptide.
And fasting insulin, you mentioned, that's not something you're typically going to get from a typical primary care panel.
Yeah. And if those are an issue, we generally hook people up with CGMs for a few weeks and kind of get an idea on what that's moving forward. And yeah, I'm sure I'm missing something outside of hormones and everything as well. So estrogen, estradiol, progesterone, testosterone free tea.
And what fraction of
all
your
that.
clients are women and men thinking about hormones?
You know, I was looking at this the other day. It's I'm probably about kind of half and half, maybe 40% women, 60% men
Okay.
right now.
Yeah.
Yeah.
Yeah, that's great. And then, I mean, you mentioned you kind of got into this from the longevity angle.
Mhm.
What do you think about the biological age sort of testing and assessments, and how does that fit into your program?
You know, so we're doing those now. We're doing the true diagnostic one. Um, yeah. I think I'm excited about where all the epigenetic testing is going. As we've talked about, not really perfected right now. I don't like, and I agree with you about the biological age. I love it that you did a true diagnostic the same day. That was so irritating. So yeah,
20 years apart,
yeah,
two tests on the same day. Yeah.
yeah. But so
But you currently use that.
yeah, we do use that. That's part of our what we call the our initial
Yeah.
consultation.
And how does that change the way you treat your clients, the result from that test, or does it?
Yeah, you know, usually that kind of confirms what we know a lot of times already. So it doesn't change very much, but it does give, I think there's a lot of value in the client or patient knowing kind of what cards they're dealt. And all this we call about, we call it getting the fingerprint of the patient because
Yeah.
it's all very individual.
Yeah.
So if I know from your history that you sleep like garbage and there's some other things, and I know that, from physical exam that you might show some signs of insulin resistance and the labs may look like that. But if I can let kind of quantify that specifically with epigenetic testing, that's just going to give you more knowledge as a patient to be more efficient on acting on those things.
Yeah.
You know
But
what I mean?
what if the biological age test doesn't match up?
I follow the I follow the biomarkers. I follow the labs. I mean,
Right.
that's
Right.
That's I kind of tell people that's a kind of for fun. It's interesting. We're gonna go with it.
I mean, I think I think my concerns, but my concern is that the direct to consumer biological age tests, the variance is so big that it's almost random what you get back, and so I feel like there's a lot of confirmation bias in the way these are being used, where if it matches what I think I already know, then I'll believe it. And then I might talk about it. But if it doesn't match, then I'm like, oh, this is just entertainment value only. Yeah. So anyways, so you do one epigenetic test right now, currently.
We used to do more, but we've
pared down. And why did you stick with that?
Well, okay. So I'll tell you this. So I've got a patient who, I love all my patients. They're almost like they've turned into my friends. They'd all get together if they were at a dinner party kind of thing, which is
that's cool.
Wonderful. But great guy, still smokes, trying to get him to quit, but he knows he needs to quit. He saw this, his biological age was 10 years advanced, right? He's our age, it showed him to be 60. So and all the markers were very, a lot of inflammatory things. And just kind of from that, it really got his attention, and it matched again what I already knew.
Right.
But that I saw the look on his face. It was like, okay, and he really.
So you think that was more effective at potentially changing his behavior than the blood work would have been, or other things?
Yeah. So my thoughts have kind of changed on this over time.
Sure. And it's evolving space. I totally get it. Like I was pretty bullish about these tests until I did the experiment myself and just saw it was all noise. But I think this is an interest. I hear people say this a lot, that even if there's no scientific value to it right now, at least the direct to consumer tests, it as a motivational tool, it can have a positive impact. I guess the flip side question I would ask is, have you ever seen it have a negative impact on people? Because I'm sure that's real for some people, right? In the sense that it is, psychologically detrimental to see a result that maybe doesn't match. Like if you've really made an effort to improve your health and your other biomarkers are going in the right direction, and then you get this spurious, higher biological age.
Yeah.
Have you seen that in any of your patients, or has
Like
it
where it's
not been
almost
an issue?
depressing for them.
Yeah, or demotivating or
Yeah.
something. And I don't know if they would even talk about it, or maybe you
Right.
don't emphasize the biological age test in that situation. But
Yeah. No, I haven't seen that so
yeah.
much as far as a negative effect.
Yeah. And I mean, again, I'm also
Yeah.
sort of, from a personal, I may have said this on the podcast before, but,
Yeah.
like when I got the data back and, I saw the numbers were all over the place. I'm like,
Yeah.
okay, this is statistically, this is garbage,
Yeah.
right? It doesn't mean anything.
Yeah.
But even still, the fact that the numbers, some of them were really high and the average was right on my chronological age, it kind of pissed me off. Like, I'm like, come on. In every other metric, I'm doing really good.
Yeah.
And so it bothered me a little bit. Now, it's not like it depressed me. It didn't cause me to stop doing what I'm doing. But even though I knew, I'm a scientist and I know the statistics and I know that's garbage, it still bothered me. So I just wonder for some people if it does have that sort of an effect.
Maybe they haven't told me. But no.
Yeah. So anyway, so so what other tests do you do? So you do blood work. You do the True Diagnostics epigenetic test. You do DEXA, VO2 max.
Yeah. Those are more important, yes.
Anything else that you typically will look at, or is it sort of become a one-off, okay, we're going to give you a little bit of extra attention on the cardiovascular side?
Yeah. Like we talked about clearly, yeah,
which is interesting. You want to explain what that is?
Yeah, so it's a CT angiogram where you can get that, and then we look at software from that. A lot of it's read by AI and all that stuff, and then you go over it with them.
So it's a traditional CT angiogram.
Yeah, pretty.
And then,
really
but the clearly part is the software piece and the AI component that is more able to identify hard plaques and soft plaques. Is
correct.
That the idea?
Yeah. So it specifies, calcified versus soft plaque, and your arthromal load and everything.
Yeah.
But it's just if you're going to talk about longevity, you've got to dig deep into the number one killer of both men and women.
Yeah.
Right?
Yeah. Right.
So
right. Well, and again,
useful.
you tell me your perspective, but it's my understanding that again, the lipids are pretty good at a population level in the sense of predicting risk of cardiovascular disease, but there are many, many people whose lipids could be perfectly normal, and they're going to have advanced plaques, right? And then there are going to be people whose lipids are by reference ranges not good. They're going to be completely clean, right? Does that match sort of your perspective and why you would want to do the imaging to find out?
Like, you mean if somebody's ApoB was elevated and their vessels would be clean?
Yeah,
that kind of stuff. Yeah, I mean, people know when they're a legitimate disease, and that's actionable, right? So if somebody's got, I don't know if this is answering your question, but if they've got if they got horrible lipids, and if they've got a plaque load which isn't quite as bad as we think.
But you're only going to know about the plaque load if you look, right? I guess that's what I mean is the lipids will give you at a population level a pretty good picture of who's at risk.
Right.
But the lipid risk doesn't always match up when you look at the plaque load as to what you see at the individual level. Is that right?
Yeah, that's the end game, seeing imaging actual load.
Right.
What's actually there.
So why don't we do clearly for everyone? Cost?
Probably. Yeah. And there's a lot of things. I mean,
clearly is a brand name, so maybe we shouldn't say that, but this type of imaging for everyone.
Yeah. Yeah. For guys in their 50s who are at risk, that's who I've done it on.
Yeah.
It's a CT angiogram. So there's always, anytime it's considered a procedure, there's always risk with procedures, but
what are the risks in this case?
I mean, in this case, they go in with a line, it's not.
There is some radiation.
Yeah. There's some radiation and all that. And it's a cost of,
Yeah. There's the financial piece. So ballpark, what does this cost?
I think it's like $1,600.
Okay.
Not quite 2,000, 1,600.
1,600. Yeah. Okay. So less than a whole body MRI, at least at most places. Yeah. And a whole body MRI will not pick up what clearly is looking for, correct?
No, because you're doing dye, you're actually looking at the vessels, very specific.
Right. So it's just worth explicitly saying that so people don't wonder. Okay. So I'm gonna go give it a try because I've been meaning to get a calcium cardiac scan anyways, so I figure why not check it out and see. So I'll do an episode once I do that and tell people what the experience was like.
Great,
but
cool.
It seems like a really valuable thing to do, especially if you have any. Well, obviously if you can afford it, but especially if you have any risk factors that would suggest that maybe you want to know what your plaque load is. So that's one of the specialty procedures you might
Right.
suggest that somebody get. What are some of the other things that you commonly see, or some other procedures that you think for certain subpopulations of people, this is the right thing to do? And actually, do you do multi-cancer detection?
Oh, sorry. Yes, Grail.
So
Yeah.
Grail is one of the part
Yeah.
of your standard
Correct. Yeah.
panel. Is that annual for everyone, or?
If you're 50, north of 50,
Okay.
recommend if you can doing that once
Yep.
once a year. But it's
Yep.
it's not and it's worth noting. I mean, that's great for some cancers. Not all cancers are going to be picked up. So it's, usually your fast growing cancers.
Right.
Which is actually in my mind great, because those are ones we don't have screening tests for.
No.
Right?
Yeah. I mean, I think again, we use we use the Gallery test in our program as well, and I think that's one of the reasons why we made the decision to use it was the idea that it's going to miss some cancers.
Yeah.
There's going to be potentially some false positives, although we haven't seen any in our program yet. But it's more able to detect the aggressive later stage cancers. And again, those are the ones you really want to make sure you find out about as early as you possibly can.
Right.
So, okay. So multi-cancer detection using Gallery. Do you typically refer people for whole body MRI, or is that not something yet that you're
we are,
using?
that's not part of our, initial consultation package deal, but we have done that. And yeah, it's been useful.
Yeah. Anything else that is common that you have a lot of people do on the diagnostic side?
Of course, ApoE, and
Oh,
then
genetic
looking into
testing.
that.
Yeah.
Looking for cognition, issues, and we're kind of starting to incorporate further in the, not everybody, but the MRI, brain, like NeuroAge, brain key, all that kind of stuff, to really get a look at cognition evaluation.
Yeah. Obviously, cognitive health is super important. So again, to bring it back to sort of the overarching topic, if you have a good concierge doctor, they will be able to help guide you towards the sort of specialty diagnostics that are going to be most relevant for you. Again, if you're independently wealthy and you can afford to do everything, great. Great on you, but most people aren't. So you can sort of stratify people into risk factors, into to buckets, and say, okay, you really need to go get clearly somebody else maybe really needs to go get a whole body MRI or a brain MRI, or probably do the genetic testing for everyone at this point.
Yeah. At this point.
Yeah. I'm interested to hear kind of what your thoughts are on how you're starting to integrate artificial intelligence tools. I'm thinking concierge medicine is where we're going to see this first, right? So how you're starting to think about and integrate AI-based tools into your practice, and kind of where you see the potential wins in medicine for AI.
Data acquisition, literature searches, kind of, because that has exploded. The information is coming at an exponential rate, really, right? And to stay on top of that stuff, that's a useful tool to look up and then find certain journal articles or whatever on certain topics, and then collectively get those together. And that I found to be super helpful. Of course, the mundane things of data entry and, charting.
Just
automating
automating a lot of the tasks.
That's nice. So I can spend more time, face to face, not have to worry about that. So that's been huge. And there'll be, the thing with AI is there's ways to use that I haven't thought about yet.
Sure. That's true with all of us, right?
Yeah.
And as these tools get more powerful. What about transcription of conversations or things like that?
Yeah, we do have access to, kind of a scribe kind of thing, to where that can put that together. So you're not, before I even used that, in this practice, I wouldn't, I would just recall everything and try, and that could be difficult, because there's a lot that happens, because, you're having an hour-long conversation with a patient. And you can't sit there and, type and not pay attention to them. So.
Yeah, that's one of the super easy, low-hanging fruit things we've found, is that you can use, transcription tools combined with large language models to summarize interactions and capture the key points of those interactions,
Mm-hmm.
both for the patient, right,
Mm-hmm.
and confirm with them, this is what we got, this is what we talked
Yeah.
about. Does that match what you recall?
Yeah.
But even maybe more importantly for the doctors who may not see that person again for 3 months,
Mm-hmm.
right? Then you have this record that you can go back to
Mm-hmm.
and quickly refresh yourself. So
Yeah.
again, it's a pretty obvious use case, but also very powerful.
Mm-hmm. Mm-hmm. Yeah. And just in the moment too, when you're not, typing, if you're typing or,
Yeah,
trying
you're not
to write,
always listening. You're not
exactly,
catching
you're
everything.
missing pieces, and it allows
Yep.
you to truly be engaged
Right.
100% of the time.
Although you do have to be careful because even still, sometimes the LLMs will kind of make up little details that didn't actually happen.
Yeah.
I don't know if you've come across that.
Yes. Yeah. It's not foolproof, man.
So we first met at the American Aging Association conference a few years ago now. And I get the impression that you are atypical in the concierge medicine space as a MD that actually goes to scientific conferences and interacts, right? And I mean, I get obviously I think that's great.
Yeah.
But there are also these conferences that are more for I don't know, maybe you can give me a better way to say this, alternative medical providers.
Uh-huh.
And so I'm wondering, first of all, interested to get your thoughts on the first part of what I said.
Right.
And then secondly, what you think of those types of conferences. And then I guess the broader question is, how do we start to really merge these things and make the longevity medicine, health span medicine, whatever this ends up being called, both, clinically viable and scientifically rigorous?
Mm-hmm. Yeah, it's got to be married. There's such a, and I never really thought about that so much as whenever I showed up at the first conference that was in my hometown, because I talked to Ben, from OMRF,
Right.
and met him. And,
Ben Miller.
Yeah, Ben Miller.
Who, by the way, is the president of the
Yeah.
American Aging Association now,
Yeah.
and chairing the meeting in Anchorage in May, which I'm going to.
Yeah.
You should go.
Yeah.
You should go. It's going to be fun.
So, and I met him, realized they were doing longevity medicine in my hometown at OMRF. And then he said, oh, and we talked about, conferences and things. And there's some that I go to that the science is, good, but then there's some that's not quite so good. I mean, there's,
but I would also say
bag.
The ones you go to that the science is good, there's very little clinical stuff happening.
Yeah.
Right. So
So it's, you're right. So whenever I went to the first one, I kind of realized, and you never thought about that. There are the people on the front end doing the real science. They're like the quarterbacks, and we're just the receivers making the touchdown. Without the guy throwing the ball, it just doesn't happen. So, that was really eye-opening to me, and I thought there should be more clinicians going to this and just kind of being exposed to this piece of it.
I agree. I wish there were.
Yeah.
There's a few, but it's actually still pretty small number of people. And I think she'll be fine with it. But it was it last year, right? Mm-hmm. At the Age conference, I think it was you and Mary Pardee, right? As far maybe I'm sure there were probably other clinicians there too.
There was no more. It was just us.
and actually, so as you know, I'm going down to visit Mary next week, and we'll do episodes for both of our podcasts.
That'll be good.
But
you're doing that.
We need more docs coming into this space who really want to understand the science and interact with the scientists so that we can really raise the level of rigor in longevity medicine or health span medicine. Again, whatever words we end up using in this sort of medical care. So you and Mary, we need more of you guys to get engaged. So in addition to the people who come to your clinic, who maybe already have a pre-established interest in longevity or health span, you have some athletes who are also clients of yours, and maybe even some professional athletes. So tell us about that, and how do they differ from your other clients, or maybe they don't?
There's a lot of parallels with longevity medicine and performance, really. So our guys are interested in performance, recovery, optimizing their their athletic abilities and
Yeah.
stuff. So really focus on those things. So that's a lot of fun to work with those guys. They're very motivated. So it's very specific. And so, yeah, we have a professional basketball, player that kind of,
I don't want to talk about professional basketball in
Yeah.
Oklahoma City.
Yeah.
You guys stole our team.
Oh yeah. There's a lot of, story about that. It's been good for us, but
Yeah.
but yeah. And then there's, some football guys that have come around. So those are great.
Yeah. And I mean, you're right in the sense that there is certainly a fair amount of overlap between health span optimization, maximizing health span, and maximizing physical performance for sure. So not everything is going to be the same, but there's a fair amount of overlap. Yeah.
Yeah.
Okay. I know I'm sort of jumping around here, but one of the things I'd be interested to get your take on is what do you see as the pros and cons or maybe differences in concierge medicine by telehealth versus concierge medicine in person, the way you do it? And how, do you do any telehealth? And if not, why not?
Yeah, I do some telehealth. The majority of our patients have seen me first in person, which is
so they come for the first visit to see you, and then
they don't have to, but I prefer that. It's just great for building the relationship, because that's what concierge thing is all about. You got to really have a good rapport, and so that happens best.
Well, that's the way you do it, and this is sort of why I was asking, because I think there are other concierge providers that are completely telehealth for sure.
Yeah.
And I was going to say don't value that in-person piece as much. Maybe that's not the case. Maybe that's just not part of their business model.
Yeah. Yeah. And we do have some patients that are just telehealth, it just depends on the situation.
Yeah. But do you feel like, I mean, I don't want to put words in your mouth, but it sounded like you were saying that you feel like that personal connection is a really valuable piece of the relationship.
Yeah. The organic in-person kind of thing. Yeah. It's always beneficial.
Cool. Okay. So last question, because I know this is like probably the most important one. Probably should ask this first, but so for people who are interested in exploring concierge care for themselves, how do you find a good doc? Like, what do you look for? Other than going to Kevin White's clinic and
just come see me and it's fine. It depends on one, what are you looking for? If you're looking for longevity and proactive and the 3.0 lens, then that's a different, you need to go, there's some different ways you need to look for that. If you're just looking for, primary care stuff and availability, I mean, there's the direct primary care model. It's cheaper and they just do the same stuff, but they just it's a little bit more accessible, and that's vanilla, right? So, and there are some ways to do that. You're not going to find everybody, but I mean, there's different, if they're a member of, and have gone through training and have gotten boarded in, IFM or A4M, which is, Institute of Functional Medicine, or A4M. Is
and I'm going to put you on the spot. You can dodge the question if you want to, but I guess my question would be like, how valuable is knowing that somebody is IFM or A4M? Like, does that guarantee they're going to be a good doc?
Or by no means. No, gosh, no. So you have to just go and be able to meet them. I mean, that's why we have the lead initial consultation,
right?
Where they can meet us, we can do an evaluation, they can see if it's a good fit.
Yeah.
And then if they decide to stay on, I mean, they can pay by the year, but it's just a agreement. It's not like a 2-year contract or anything like that they're locked into. So they need to feel like there's an out if they don't like this guy. So a lot of it has to do with, gut feeling, and what do you check?
Connection.
Are you checking an ApoB, LP-A? Do you know what that stuff is?
Right. I think that's where I would immediately gravitate towards, is like, what are some of the things that if this doc is not doing this, that should be a red flag. And I think, some of the markers we've talked about, the diagnostics, which we can put in the show notes, but if they're not doing that, maybe not up to the caliber of what you're looking for.
Yeah.
And then on the flip side, are there any red flags that if somebody's doing this, I might go look somewhere else?
And another thing, You're going to have to go visit, see him, right? But I mean, asking him, how do you stay up on the literature? What do
Yeah.
you do? What kind of things,
Yeah.
what do you read? So getting to know them, asking them questions. So you shouldn't feel rushed. And if he's confident, he'll answer those questions or she'll answer those questions. And,
Right. Yeah.
those are things you need to make sure it's a good fit for you too.
Yeah, I would agree with that completely. And then I guess the other thought I have is, it seems to me that there are lots of people in this space who just like latch on to the current, shiny object and start selling that to all of their patients, right? And that can be in the realm of supplements. It can be, new diagnostics. And so, that's harder, I think, for the average person to be able to know what's real, what's not. But, if it's somebody who keeps jumping to the next thing or trying to find the new thing they can sell people, to me, that it's a pretty common phenotype I've seen. And I think is indicative of somebody who's not really doesn't have the best interests of their patient at heart. But it also seems like that's part of some of these conferences is you get a lot of companies going there trying to sell you the latest, greatest gadget.
Oh, yeah.
Right?
Yeah. A lot of smoke and mirrors and shiny things. Yep.
Okay. Well, this has been great again for anyone who is in Oklahoma City or who wants to go to Oklahoma City. Check out Kevin if you're looking for a concierge.
Yeah.
Yeah. Oh, you're open anywhere now, huh?
Yeah.
And of course, Optispan.
Yeah,
you should check Optispan out. But I think there's actually the one thing we didn't talk about is in this realm of how do people find good care if they want to look for this kind of care. Right now, it doesn't seem to me that there is a really solid network of high quality docs or clinics that we can point to say, yep, this is somebody I feel really good about. Like, I mean, how many docs do you know just off the top of your head? You don't have to name them, but how many do you know where you're like, yep, I'd trust that guy. I'd go see that guy if it was me.
Yeah.
Is it a small number? Is it a big number? Yeah, in this space. Yeah. Yeah. In the concierge. Two, right?
Yeah.
Right. So I think there's
three, actually. The third one I can't afford, but two.
Yeah. It's a small number, I think is the point. Right. So I think it doesn't mean that there aren't other really good docs out there.
Right.
It's just that we don't have yet a really strong network of like-minded people who have come together and, and again, I don't expect everybody to agree on exactly what we do, all the same stuff, but I think we're going to have broad agreement about the way we think about and approach health and the kinds of things we measure. And I just haven't seen that coalesce yet. I've seen a few, groups pop up where they're suddenly trying to brand themselves as like, the longevity doctors, right? Or whatever. But so far they don't seem very credible to me.
Well, I mean, some of the, A4M and IFM, there's a lot of good physicians that come out from their training programs and everything. But like you said before, it doesn't mean that they're all,
have you done both the training programs?
I've done some from, I've done the A4M track and and their board exam and stuff, just because it's great information and all that. But it's
I'd be interested to check it out because I wonder how accurate it is.
Yeah.
Of course, I naturally do. That's me.
Yeah.
I'm going to be super skeptical. Yeah. But I just wonder how good is the information.
Yeah.
But it seems like you think it's pretty good.
Yeah. Yeah, I do. I mean, actually, I would love for you to go to just see you rip stuff apart. It'd be great. It'd be a lot of fun.
Well, I think the conference is different from the educational material. Hopefully.
Yeah. Actually.
Hopefully it's different.
Yeah. It is.
Yeah.
Yeah.
So anyways, that's something that maybe as a take home that I would really like to see is if we can coalesce around a network of people in this space, and it's not only going to be docs, because I consider myself part of this community as well, who really want to do this at the highest level and are both rigorous in thought, critical in thought, but open to learning, right? I think curiosity is a huge part of it.
Yeah.
Staying curious, wanting to learn, really wanting to do what's best for as many people as possible. I think there's a huge opportunity here. So we just got to find those people and bring them all together.
There are a few other names of other physicians I'd So I'm going to make that list 5. I'm going to
Okay.
add to that.
All right. Well, we
It's
should
still not 50 or anything.
It's
but
a starting
5 or 6.
place. So
yeah, sure.
look, I'm sure there are some people out there, scientists, docs, other people in the space who are super motivated and passionate about this watching right now. Like if that resonates with you, like let us know. Let's figure out a way we can bring the best of the best together.
Yeah.
Get this thing going because there's a big opportunity here.
Yeah.
Awesome. All right. So Kevin White, one of the good guys. Really, thank you for coming on the podcast. I'm sure we'll do it again at some point.
Always fun. Yeah. Thanks for having me. It's good to be at the OptiSpan mothership.
Yeah, it's a lot of fun here. When it's not snowing. So again, thanks everyone for tuning in to this episode of the podcast. As always, if you have any comments or questions, leave them below. If you're not yet a subscriber, I'm done. Like, I don't know what else to say. Hit the goddamn button. And definitely hope to see you next time on the podcast.